So I was asked to speak about why science matters and to highlight inequities in maternal and child care. And I thought I'd illustrate this with the experiences I've had working in the global south, not just in Pakistan, but also where I started my research journey in Southern Africa. And if Professor Farah is here, I just want to say that actually the bug I'm going to talk about is way more interesting than the one you talk about, but we can argue about that later. Okay, so I want to start by going back to the early 2000s in Southern Africa. And, you know, that was a time when I arrived to first work there, when the prevalence of HIV infection, which is what I'm going to use to explain inequity and why, to illustrate how science is important, where the prevalence of HIV in the general population, and not admitted patients, but in the general population was 20 to 30%, which means that you would walk out onto the street and out of 3 to 5 people, one would be living with HIV. And I would regularly walk on the street and see people with lymphomas and tuberculosis and Kaposi sarcoma, things that were very, very visible, people who were wasted, etc. And this was a sign outside my house which shows the nihilism and the hopelessness that existed at the time. And when I was practicing on the wards as an adult doctor, many of you won't know that I'm actually not a pediatrician, so I'm intruding into this conference today, but I will hopefully illustrate why I hopefully am fit to be a member of the Department of Pediatrics, is that 80% of all our admissions had AIDS. That said, what we knew about children at the time was that HIV was associated with very rapid disease progression. And I think you can look at this Kaplan-Meier curve, which is published in the Lancet, a meta-analysis of data on more than 3,000 children from 7 trials, which showed that by the time children born with HIV were 2, 50% were dead. And I think you can see that in the curve very well, that by 900 days, more than, more than 50% were dead. So what the received wisdom was that there would be no child alive beyond the age of 5 years because they would have died. Okay? So what I saw in clinical practice, this was what I saw. These were children in Zimbabwe where I worked. You transition from pediatrics to adult at the age of 12. So whilst I was trained as an adult internist, I was seeing children that I had very little experience of, albeit older children. So these were the conditions I was seeing, and I don't know if they project: children with strokes, children with seronegative arthropathies that were burnt out. These were children that had been in wheelchairs for ages. This was a 13-year-old who had a stroke many, many years ago. Children with Kaposi sarcoma, which in Africa is pathognomonic of AIDS, children with uveitis, and children with these warts that I would often see on the streets, right? And I just say that these are all consented pictures. And what bound them together, and the reason that they got bound together was they all had HIV. And the question then arose was, how did you have 13-year-olds, 12-year-olds that had HIV with these conditions that clearly had taken a long time to develop, whilst we had thought, or the received wisdom was, that all children would be dead, which was not what we were thinking about with adults. Adults had had HIV treatment, adults were being focused upon, but when it came to children, we were thinking about preventing infection in babies, but nobody was thinking about these children. So I think the one aspect of it is that, you know, we do science to address and improve the health of the people we serve. And the questions arise at the bedside, and we need to be open to questions that arise when they don't make sense, because these children received little care in terms of the fact that they would be treated for these conditions or not treated in the case of those who had chronic conditions, and they would be discharged. And nobody really asked, why does a 13-year-old have Kaposi sarcoma or cryptococcal meningitis or any of the other AIDS-defining conditions? So that was, for me, the real epiphany moment for why science is needed, to challenge the status quo. So this was just showing a study that modeled estimates, because there were no estimates that existed. I mean, empiric data on survival, because nobody studied children, because children were meant to be dead by the age of 5. So why would you have children? And we gathered survey data, looked at estimates of child mortality, maternal fertility, maternal mortality in the era of AIDS and HIV. And what we rather surprisingly found was that the survival of children was much longer than had been thought. That a third of children actually have very slow progressing HIV disease. And because they had had little attention, that there would come a time, and we projected the epidemic, that the deaths in older children would overtake that in younger children who were, the infants that were receiving attention. And really, that was something that the community was really ill prepared to accept. At the time, it's a 10-year-old, you're not going to test that person for HIV because they don't exist. And it then it just shows how long translation takes for those to be translated into WHO data. This data was something that was the first estimate that we modeled, and that took years later for it to be translated into estimates. And those estimates are really important. The science we do and we put out is really important because it helps change how we address things. But modeling data is not enough. We then went on to actually have empiric data and empiric studies that showed that this was a real problem in children. So rather surprisingly, again, we showed that of the children, the older children, age 10 over, that were coming into hospital, nearly 50% were HIV positive. Whatever reason they came for, that most of the admissions in hospitals in Zimbabwe, which broadly mirrors Southern Africa, were due to HIV. And without us realizing it, HIV had become the leading cause of death in children and adolescents. They were mostly undiagnosed, mostly had AIDS. For those of you who work in the field will know that a CD4 count of 150 is super low and puts you at risk of really advanced infections. And even when we looked at primary healthcare clinics, nearly 20% were coming in with HIV, but they were not coming in with HIV, they were just coming in. And the thing was that the question was that there was a received wisdom that HIV is acquired through sex. So these 13-year-olds, 14-year-olds would have got it through sex. So there was no way we could prove that biologically, and that's what communities, academic communities want. So we did a proxy of herpes simplex virus 2, which is sexually transmitted infections. And what you can see is that amongst 10 to 19-year-olds, in both HIV positives, and the prevalence was really high. But if you take those that were coming to acute care, the prevalence of HSV was very low, which would be consistent with the fact that the HIV would not be sexually acquired, because you would expect much higher HSV2 prevalence, because it goes really strongly correlated with HIV. And I think that was a real paradigm shift in HIV care for children in the world. Particularly when I say world, because 90% of children with HIV live in Southern Africa. We had obviously had at the time focus on prevention of mother-to-child transmission, because it is recognized that 90% of children live with HIV are infected by vertical transmission from their mothers. But what then followed after these findings was a real focus on older children. From a time where I would go onto the ward and ask for an 8-year-old to be tested, and they would say, why would you test that? That's a waste of resources, to now developing strategies for 9-year-olds, 15-year-olds, appropriate treatment, weight-based dosing. How would you dose somebody who is 17-year-old but weighs 18 kilograms? Adherent support interventions, recognizing that adolescents and older children find medicines difficult to take. And now a real emerging focus on the longer term comorbidities that are emerging. And these all come from clinical observation. But the point I want to make to you is that for years and years that epidemic had been emerging, and yet had received very little public health, WHO, international focus. And I hope that illustrates why what we all do as science is so critical. And, we talked about inequities, and there still is, despite all of that, a very persisting inequity in how HIV is managed. And that is a point that I'm trying to make, is that there's a lot to be done. Whilst the coverage of HIV treatment in adults is around 74-75%, in children, it remains lagging at around 50%, so that half the children with HIV in this world remain untreated. And the other thing that I want to point out before I come to Pakistan is prevention. It is possible to eliminate HIV that is maternally acquired, i.e. from mother to child transmission. And we've made huge progress. What you can see in the yellow bars, which is the way you do that is by testing every pregnant mother, putting her on treatment. And then when an infant is born of a mother who lives with HIV, is to test their children within 6 weeks of birth. But you can see that we started out really well. We moved from about half of mothers being tested and started on therapy to progress stalling at about 80% globally. And then if you look at children being tested, we started at around 18% of infants being tested to about half the children born with who are born to mothers with HIV globally are tested. So progress is stalled, so we are still getting about 100,000 babies, more than 100,000 babies born with HIV every year. But I want to focus now on why and how this relates to Pakistan, because Pakistan has a very unique situation. Now, most of you will probably kind of think, how is this relevant to pediatrics? Most of you will think that the HIV epidemic in Pakistan is focused on populations that you don't often interface with. And there's a very beautiful article by a group at AKU, by Bushra Jamil and colleagues, that has basically looked at the very tight, interconnected epidemic that we all see, which is called a concentrated epidemic, which is confined to men who have sex with men, people who inject drugs, sex workers, and transgender groups. And they're very tightly interconnected. And what you can see they've shown at the bottom is the prevalence amongst those groups is really high. Nearly 20% in men, people who inject drugs, and about between 5 to 10% in the other key populations. And what we have seen, which is really something that we've got bored with, is the fact that and I say bored with because it spurs very little action, is intermittent reports of outbreaks of HIV in the country. And these have been reported for the last 24 years. And I've just put down about 7, but there have been far more. These are the ones I could fit in different settings, right? But the one that really sort of made headlines and has broken a paradigm shift is the epidemic of HIV that occurred amongst children. And this was the first time an outbreak occurred, or an outbreak, I'd say in inverted commas, because it was a large number of nearly 2,000 children who were identified with HIV in Sindh, the province that we all serve most directly. And the remarkable things about it, it was a huge number. We just not had 2,000 children in care anywhere. At AKU, we're talking double numbers, not triple numbers. Secondly, all the outbreaks that had occurred previously had largely been amongst adults. And thirdly, which is probably of something that should really concern us, is that outbreak probably wouldn't have come to light if the pictures of those kids had not been shown up on television, which hopefully will help us question our approach to public health. And what we can see here is that there was a testing drive, and the percent, 3%, 2% kind of prevalence amongst the children who were tested. And this equates to the prevalence that we see at population level amongst children in Africa. So obviously this was amongst people who tested, really high. And it was time limited, as you can see, because the blue line shows the number of children who were tested, and after a while it dropped off. That means that the testing campaign was over, okay? But why science matters is because we needed to know where it came from. Now, I said earlier that the assumption by WHO and the world is that 90% of children are born or get HIV through their mums. When we did a case control study led by Professor Fatima Mir in the Department of Pediatrics, what we really ashamedly showed is that incredibly, either visiting a government hospital, visiting a private clinic, having a blood transfusion, having surgery, and indeed having a positive test in the mother were all strongly associated with being HIV positive. Now, these are, of course, a very coarse estimates. What does going to a clinic really mean? Where is it happening? But for the first time, we also saw that there were children whose mothers were negative. So unlike the assumption in the rest of the world that children are getting it from their mothers, we know that they are not getting it from their mothers. And I think what shames me even today, that clearly these children are being infected parenterally. They're being infected by dirty blood. They're being infected through surgeries. They're being infected through government health services. They're being infected by what we do. In Pakistan, unlike anywhere in the rest of the world, it is an iatrogenic epidemic. And that is why we need to do science, because it helps us identify issues that we just keep buried. And I think it fills me with shame that we've got children who are the future of our country are being harmed by us. And that's not something we don't know about. You know, this is a picture from the Herald in Pakistan in 2017. But you know, there are a lot of questions that remain answered, and this is an invitation for those of you who might think that HIV is a problem of another part of the world. It is a question of what the inequities are in adult versus child health, right? If you look on the thing on the right, the figure on the right, that's from the UNAIDS report in 2023. And what you can see at the bottom is that there's no data for what's happening in Pakistan in children. None whatsoever. It's the only country that I know, and I know the stats really well for most of the world, because that's what I work on, and this is one of the few countries where there are so many blank patches. What's also really concerning is if you look at the graph, the numbers of deaths that have just shot up, and Pakistan is silently having a real expansion of the HIV epidemic. And importantly, in children, it's happening in both groups, right? It's happening both through mother and child transmission and also through parental and blood products. But we don't know how it got to them. How did the mothers get it? I mean, their husbands are likely to be the sources, but where did the husbands get it from? They're not all key populations. Their husbands are not people who inject drugs. So it is in the general population. Where did it enter the hospital system? Because this is not, I mean, the response was shut down the quacks, but it wasn't just the quacks, because we know it's also in the government systems. It's also in the private healthcare system, but we don't know it. And the thing is, the statistics as a result, and our programming is really troublesome. I showed you that 80% of women are receiving antiretroviral therapy. In Pakistan, only 11.9% of pregnant women receive antiretroviral therapy, with HIV, I mean. And unlike the 50-60% of infants who receive, in Pakistan, only 2.8% of HIV-exposed infants are tested by 2 months of birth. And a recent study, which is ongoing, which we hope to publish soon, will actually show empiric data. These are UNAIDS estimates. The question is, what's contextually relevant for us? In other countries, in the rest of the world, I would say, because the assumption is that it's mother-to-child transmission, we opt-out test everybody. We have 9.7 million pregnancies a year in Pakistan. Is it feasible and cost-effective when the population prevalence is very low? In fact, we don't know what the population prevalence is. All we know is that key populations have HIV, but then we don't know how they got into the system. So the connections have just not been made. The second question, so are we going to test everybody? Pakistan has no plan, no concerted plan for elimination of mother-to-child transmission. And this is in the face of one of the few countries that WHO has highlighted where the epidemic is taking off. And having worked for 20 years in a country where it suddenly, silently takes off, I can tell you that it is happening without us knowing about it, because the infections do not manifest themselves. People die of malnutrition, children die of pneumonia, children die of TB. You don't know whether they've got HIV, right? Because it's not manifesting as a disease. HIV manifests as a syndrome of conditions that are already commonly prevalent in Pakistan, well, are already commonly prevalent in many settings. And then if we are going to intervene, at what point in the healthcare system does it happen? I mean, we know that going to health facilities, is it the fact that somebody touches the waste, which is often found lying around? Is it something that needles are not being changed? Where is it happening and how do we intervene? And also an important question is there another source in this country that we don't know about where fluid contact is happening? And there may well be. And the reason I say that is because it is important. It behoves us as scientists to not accept the status quo. And I'd like to end by a couple of reflections about why science matters. And I hope I've illustrated that. Firstly, it is about challenging the status quo. Disease epidemics, as I showed you in our work from Zimbabwe, where we just accepted that children would be dead and didn't realize that there was a bunch of children or a group of children that had grown older under our noses. The disease epidemics are dynamic. What's true today may not be true in 10 years' time. And another reason we do science is to shed light on issues that remain buried and answer questions the society is unwilling or simply unprepared to address, and that requires a lot of courage. And importantly, both those informs how we respond. And I hope I've also illustrated that, interventions that exist and are passed down by the wisdom of the world are not always contextually relevant. And they may not be acceptable, affordable, and feasible in the delivery of health. And we need to be making very carefully planned questions to ensure that the questions that get developed and the questions we ask are those that are relevant to context. I'd like to thank you for listening, and I'd be very happy to take questions if needed. And thank you very much for listening to me.